So shalom, good afternoon, good evening, and good morning, depending on where you're following this meeting from. I'm really happy to see that we have participants joining in from all over the world. To all of you, welcome to this Bayer Israel initiated event on digital health. My name is Hugo. I'm the Managing Director and Country Division Head for Bayer Pharmaceuticals in Israel, and I will be the facilitator for this meeting. So we started planning this meeting in the middle of the COVID pandemic, but we did not want this meeting to only be about COVID. The revolution in digital health started long before COVID. It may have accelerated during COVID, but the enormous innovation and changes we are witnessing will for certain continue long after COVID is gone. But in order to drive innovation and change, we need innovative people with an entrepreneurial mindset who are willing to set the agenda and lead the way. And today, you will meet some of these people. Sean Karen, Senior Vice President of Digital and Commercial Innovation from Bayer is here. You will hear from Sigal Rosenberg, who is the CEO of Mohedet, one of the 4 Israeli sick funds. Eyal Simlichman, Deputy Director, Chief Medical Officer, and Chief Innovation Officer at Sheba Medical Center here. And also, in addition, 2 great representatives from the innovative Israeli ecosystem, Kira Radinsky from Diagnostic Robotics, and also Eyal Baum from Taito Care. Introducing the next speaker, as you understood, I'm using quotes from newspapers. Seems all the time when I'm introducing a new speaker, I'm going to do the same this time as well. And this headline was basically screaming at me and says, "The Israeli who can predict the future." So the Israeli who can predict the future, and that's just one out of many sentences that has been used to describe our next speaker, Kira Radinsky. And you may recognize the name, and some of you have maybe already seen her on TED Talks. She made Forbes 30 under 30 list. She's a computer scientist, an inventor, an entrepreneur, and she's specializing in predictive data mining. So Kira, please, the word is yours.
Hi, everybody. So at this time, I decided to talk about one of the main problems that we see today in healthcare, and so much accelerated during COVID. It's the fact that we're overcrowding that we see today in hospitals and in primary care specifically, which is causing lots of medical errors. A lot of those are eventually coming from the fact that, hey, we just don't have enough clinicians. In the United States alone, there is a shortage of 60 to 90,000 physicians. This eventually causes us to see more and more emergency department visits, and it's actually growing disproportionately differently than the population. The population is aging, and the number of emergency department visits is growing by per 100 people. And by 2030, we're going to have 3.8 billion people without access to primary care. And if today people are waiting 3.6 hours on average inside the emergency departments in Israel, 3 hours in the United States, we're talking about 8 hours and more waiting times inside the emergency departments. And again, this is not a prediction. This is how long people are waiting on average in different locations in China. So what we've been building today in diagnostic robotics is the capability of taking everything known in the medical ecosystem, specifically around primary care and emergency departments knowledge, 19 million different medical articles, billions of medical records, combining all of those and building hundreds of different machine learning algorithms capable of predicting how urgent the patient is, which test they need to do, which doctor they need to be seen. We then started working in different triage scenarios inside the emergency department. You see those AI stations. A patient would come into one of those AI stations, and while waiting for a doctor and nurse to triage them, he would answer a set of clinical questions. The system would then predict the urgency of the patient, maybe they need a test, send them those tests. While waiting for the test to be returned, and every time a result is coming back, the system updates the probabilities and creates medical summaries for the doctors. So eventually there is full dashboards inside the emergency department showing urgencies of patients, creating medical summaries for those, etc. But what I actually wanted to talk to you about is a little bit about how you build those type of systems. So I mentioned that we had access to billions of different medical visits. Eventually, those were free texts, and we needed to build a system that can read those texts, extract answers to clinical questions. So for each patient, we had their answers to triage questions, and eventually, historically, what the doctor decided to do, which test to send, their urgency, and even diagnosis. So the system would then correlate the answers to those clinical questions and the final diagnosis. From different trials, specifically in this paper, it has been shown that the system, both red and blue, are AI-driven systems. This is where the doctors, so it's not as perfect as the doctors. This is 92, doctors are at 98. And what we've been doing for the last few years is trying to close this gap between 92 and 98. So first of all, why is this a hard problem? So medical summaries are not just free text. There's lots of negation written in them. So we needed to build a deep learning model that can read those texts and identify what a patient says that they do not have a certain symptom. For this, we have an entire operation of physicians labeling texts and saying, well, this is negated and this is not. The second part is many times doctors do not write those medical summaries for an AI algorithm to read them and extract answers to clinical triage questions. Many times they have what we call latent entities. For example, a patient was admitted with a hypertension along with accompanying conditions. So for every doctor reading this, they understand what it means. For a computer, they actually need to understand more deeper what are those conditions that a doctor didn't mention, but they were probably in the text. So we started building additional deep learning models, trying to extract those latent information from the text that doctors implied but never wrote inside the text itself. We then moved to prospective trials. Our models have reached AUCs of more than 92 in retrospective analysis. But then we started noticing something very interesting in prospective trials, and we've been running those in several hospitals in Israel and in Mayo Clinic in the United States. It turns out that when patients come to the hospital and complain about a constant pain in the chest, how many times would you think the doctor would actually document a constant pain in the chest? So the following number is going to be surprising to some of you. Less than 20% of the time. 60% of the time, the doctor would write that the pain comes and goes, 20% that the pain disappeared. Here's another example. 21% of patients with a chest pain would say that the pain radiates to the left side. How many times would the doctor say that it actually radiates to the left side? 5%. And it's not because the doctors are not listening. It's because they know to ask questions in a different way, to actually understand the physical condition of the patient. This is the art of doing patient history taking. And this is the art that we must master in artificial intelligence, very similar to what doctors are doing. So instead of just asking, is this the worst pain that you've ever had? We will just ask, is this feeling like a hammer to your head? It turns out that we identify that there's many proxy questions that are eventually going to make the distributions between what patients report and what doctors document to be very similar to apply those deep learning models. So how well do these models perform? This is results from one of the hospitals in Israel working with us. So we had access with them to 800,000 emergency department visits. Out of those, 30,000 headaches, and I'm going to be showing those as an example. We had a little bit of more females than males in the data set itself. Eventually, we came to a result that 80% of the time, the system got the diagnosis right. But if you look at differential diagnosis, in other words, how many times the right diagnosis was either first or second, it's 93% of the time, and this is 98% of the time. Now remember, this is predicting the end diagnosis based on only questioning the patient without a single test. So these results are quite interesting. Of course, they cannot replace the doctor, replace the test, but indeed for triaging, they might be an extremely useful tool. We also then started predicting different type of resources that need to be done to also help as a decision support system for the doctors, or more importantly, increase the throughput to start doing the scheduling for some of those. We've reached very different results for different type of chest pain, and it varies from different hospitals, but all of them range, the lowest one is 75, some of them are 80, but we've been reaching to even higher ones like 92 and 93 for certain tests. I'm just showing you that for some, I'm not only showing for headache, we also have wonderful results for back pain, etc. All of those are already published. So let's look at a patient. This is a 35-year-old patient that comes with a headache. What a system is predicting, apologies. He came to the ED, a 5-day history of left-sided sharp temporal headache. Each episode lasts for about 5 hours. The pain is accompanied by eye pressure, sensation, pain, and lacrimation. If you ask the system what is the prediction, it says it's 99 times higher prediction for cluster headache. And why? Because of the lacrimation and pain and discomfort. Some of our predictions are completely right, and this one is correct, but some of the times if you do a physical test, like in this case, an ENT actually did an exam, and he verified that it was a sinusitis, which the system thought is only 2 times higher the probability because of the cold and stuffy nose, and because it started 5 days ago. So again, just taking the clinical anamnesis is not enough. Tests are still useful, but for triaging and understanding who needs the specialist, who needs a certain test, quite useful. And this is not only something that we've tested in Israel or in the United States. Let's take a completely different population, the Singapore Army. Let's take their headaches. A lot of them are headaches which are just general, meaning benign. A lot of migraines, much more than, for example, in the emergency department. But when we saw that we can take the models trained in emergency departments around the world and apply on this population, we're reaching area under curves which are very similar, even a bit higher. What's more important is that in the data set of Singapore, in the Army, they only had very few cases of meningitis in the past. In the hospital, we've seen so many of them that we were able to build a machine learning model, take it from and transfer this from the Israeli ecosystem, United States ecosystem, test this in Singapore, and reach an AUC of 94. When you only learned it on Singapore data, the results were good, but much lower than transferring the knowledge from all of the other countries combined with large data sets to do this type of predictions. But I started this talk with the fact that till 2030, we're going to have 3.8 billion people without access to primary care. So how exactly will automating those overcrowded emergency departments will be helpful? This is a really good question. So what we've decided is to try to take those type of systems, and this time from home. 30 to 70% of emergency department visits could have been handled somewhere else than the emergency department. It cost the United States alone around $200 billion that could have been saved. So what we're doing today, we're integrating to different health plans. During the scheduling, different digital front doors. We ask exactly the same clinical questions that we would be asked inside the emergency department, predicting that, for example, this patient probably has a UTI. Instead of them going to the doctor sending them to a urine test, the system gives a high probability, and there is an automation rule behind the scenes saying that everything above 30% should do a UTI before. Once the patient does the UTI at home or in a lab, the system comes back, updates the UTI probability to 90%. A red flag is sent to the primary care physician that can remotely approve this. So here we're talking about a system that was clinically validated inside the emergency department, but the real revolution is building what we call the digital healthcare platform that allows us to automate a lot of the workflows in primary care. Thank you.
Kira, thank you. What an amazing and interesting presentation you made for us today. I'm going to go a little bit back to my introduction of you and playing a little bit with the title you were given, the Israeli who's able to predict the future. So if I may use that one and ask you to look into the crystal ball, what do you think will be the most revolutionary and biggest changes that we will see in digital health in the years to come, except for the things that we know now?
Right. So I think what we've realized right now, as mentioned before during COVID, is there's so many things that we can do virtually. Before that, who would have thought that we can do so much business, talk to people, have webinars just like that, and not a physical conference? The same thing is happening in digital healthcare. People understand that they don't want to meet the doctor physically all the time. We understand that we have to do asynchronous methods to scale the primary care physician significantly. I personally believe that we need to start specifically with triage and clinical triage specifically that can actually help scale the doctors. A primary care physician today has on average 2,000 patients they're in charge of, 5,000 in some countries. Think about this. They cannot know what's happening with each and every patient. So proactive understanding and AI models running on this historical data, predicting patients that deteriorate, and looping in the primary care physician when needed, this is the next digital revolution in healthcare.
Thank you so much, Kira. Highly appreciated. And I really hope to see you again later at another occasion where you can give us another presentation. I know you have a lot of topics you can talk about. Thank you so much.